Good morning, everybody. As always, happy April. I hope you had a great previous month and looking forward to another great one ahead. As you see behind me, it is Celebrate Diversity Month. So happy Celebrate Diversity Month. We do have, as always, for everything we can think of, particularly the major holidays and major things to celebrate, we have Zoom backgrounds. We'll send out the link to that in a minute as more people join so they can see Zoom background. So feel free to grab one of those if you'd like to use throughout the month. We have various ones. And thank you to the communications team, Dr. Kanagawa and the team for creating these really great Zoom backgrounds. Any ones that you would like to see that we don't have in our repository, as always, please reach out. We're happy to see if we can create something to honor any sort of thing that we're celebrating. We have a really I say this a lot, but this is a very practical and really high yield important topic today, talking about sleep. Before that, we do have a couple updates. I'm going to first turn over to Dr. Dunn. Dr. Dunn, thanks for being here.
Thank you so much, Dr. Ozdalga. Good morning, everyone. And I echo Dr. Ozdalga's shout out to the communications team for keeping the Department of Medicine's Zoom background game very strong. So thank you to them again, and happy National Diversity Month, everyone. I wanted to tell everyone about an event that's happening next month, Friday, May 12th. The Stanford Medicine's 6th Annual Diversity Inclusion Forum, hosted by the Office of Diversity and Medical Education, will take place in Berg Hall from 8 a.m. to 1 p.m. And it will highlight innovative workshops developed by residents and fellows across all Stanford GME programs with their educational mentors who have participated in the 2022-2023 cohort of the Leadership Education in Advancing Diversity program, or LEAD. To give you the objectives of the workshop or of the day, it's going to be to describe the value of building leadership and scholarship capacity for trainees to improve diversity, equity, inclusion in medicine, to create a learning climate that embraces and supports the scholarship of diversity, equity, inclusion, and to implement strategies to advance DEI in your professional practice. And I just wanted to give you a little sampling of some of the workshops that will be available on that day. So there's one called Speak Up, Strategies for Responding to Microaggressions within a Power Imbalance. One called The Invisible Frontline, Recognizing the Contribution of Non-Clinical Workers in Healthcare. One called Stop, Collaborate, and Listen. Hopefully you're hearing the beat there. Reframing how we communicate about the difficult patient. And I'll give you one more, Not Lost in Translation, Strategies for Optimal Patient-Provider Communication through Interpreter Services. So it promises to be a fantastic event. There will be a keynote address by, our keynote speaker is Dr. Divika Bhushwan, and I believe she was a resident here, and she's the former California Surgeon General, excuse me. So should be a wonderful event, and I will put the registration in the chat, or you can scan the QR code on the screen. Thanks so much, and I'll turn it back to Dr. Ozdalga.
Thank you, Dr. Dunn, highlighting the diversity of our diversity backgrounds there, the different one, and thank you for all those updates. So no major other updates this week. I just want to mention that next week we have our grand round speaker, which is Cam Patterson. Dr. Patterson is the Chancellor of the University of Arkansas for Medical Sciences, and he'll be talking about challenges and opportunities in rural healthcare delivery. Next week's will be in person as well as always Zoom. We actually will have more the coming months. We'll have a more mix of in-person versus non-in-person. So please do keep an eye out for the emails to know if we're having an in-person grand rounds. We'd like to see as many people who can show up in person to do so. And as we gauge more attendance in live, we'll try to do more and more sessions along those lines. So depending on that, but we'll always have a Zoom component as mentioned before. Okay, great. And so next I'd like to just introduce our presenter today. This is Dr. Fiona Barwick, and she's going to be talking about sleep medicine. So Dr. Barwick is a clinical associate professor with Sleep Medicine Division, Stanford's Department of Psychiatry and Behavioral Sciences. She is Associate Division Chief for Behavioral Sleep Medicine and the Director of the Sleep and Circadian Health Fellowship Program. She and her team are responsible for developing and expanding clinical services for brief, evidence-based non-drug treatments for insomnia, hypersomnia, circadian sleep rhythm disorders, nightmares, and other parasomnias, and for overseeing didactics and trainings for all the postdoctoral fellows at Stanford Medicine Center. Her research interests focus on the implementation, adaptation, and collaboration for improving sleep in individuals with sleep problems comorbid with medical and psychiatric conditions. She uses cognitive behavioral techniques as well as mindfulness and acceptance-based techniques to help people fall asleep and stay asleep more easily, feel less sleepy or fatigued throughout the day, manage misaligned sleep-wake patterns, reduce the frequency and severity of nightmares. So she was actually part of a multidisciplinary group that we did back in June of 22 of last year. We have various excellent psychiatric, psychological services from different disciplines throughout our department, as well as Stanford Medicine, you see here, the Department of Psychiatry. And it was such a well-received grand rounds. We asked Dr. Barwick to come and give her own dedicated grand rounds today. She's going to be talking about a topic I think is very near and dear to all of us, and hopefully very applicable to our patients, but also to ourselves and loved ones as well. So Dr. Barwick, especially, we actually initially had planned for her to speak on another date, but she'd been so kind and flexible and filled in recently for today. So thank you so much, Dr. Barwick, for presenting and for being here, particularly today. I'll turn it over to you.
Thank you for the introduction, Errol. It's my pleasure to be here today to speak at this grand rounds. Let me share my screen with you all. Make sure I can see my own slides. I want to spend our time today talking about how to understand and manage the 6 dimensions of sleep health. I have no relevant conflicts of interest to disclose. So here are the 6 dimensions that we'll be talking about individually: sleep duration, sleep timing, sleep regularity, sleep efficiency, sleep satisfaction, and daytime alertness. This understanding of sleep health was introduced by Daniel Bicey at University of Pittsburgh in a great article called Sleep Health, Can We Define It, that was published in 2014. I'm going to be talking about these 6 dimensions in the context of behavioral sleep medicine. There's a nice definition of behavioral sleep medicine offered by the Society of Behavioral Sleep Medicine with a little bit of tweaking by myself. So behavioral sleep medicine focuses on the evaluation and treatment of sleep and circadian disorders by addressing behavioral, psychological, physiological, familial, and sociocultural factors that interfere with sleep. Behavioral sleep medicine fits very nicely within this biopsychosocial model. There's definitely a biological component to sleep and to behavioral sleep medicine. Genetics, age, sex, all of these affect sleep. Injury, disease, stress reactivity, the same. There's a psychological component to be sure. Someone has a trauma history, is prone to anxiety or depression, using substances, doesn't have great coping mechanisms. All of this can adversely affect sleep. And there's a big sociocultural component. I often tell the folks I see that sleep is a family issue, whether the family is your bed partner, your kids, your pets. Sleep is always a family issue. The degree of support or lack thereof that you get can affect sleep, as can work and socioeconomic stress, certain lifestyle choices, and cultural norms. We, for example, do not live in a nap culture, but there are plenty of countries and societies that do endorse a nap culture. So behavioral sleep medicine, sleep itself fits very much within this biopsychosocial model. I do want to make clear the distinction between sleep hygiene and behavioral sleep medicine. These are commonly confused. Sleep hygiene is a set of guidelines that by themselves are not necessarily effective. They can actually help people who are already sleeping well maintain their good sleep. If someone is sleeping well and they start engaging in poor sleep hygiene, that can disrupt their good sleep. But if someone is sleeping poorly, all the good sleep hygiene in the world is not necessarily going to help. So the sleep hygiene guidelines are things like avoid stimulants or alcohol too close to bedtime, exercise and eat regularly but not too close to bedtime, make sure you allow some time to wind down before bedtime, keep your bedroom environment dark, quiet, and cool. So as I said, basic guidelines, not by themselves enough to improve sleep necessarily. Behavioral sleep medicine, as you can see on the right, has several other components in addition to sleep hygiene. So there's certainly an educational component. Learning how sleep and circadian systems work is important. There are techniques that we use, stimulus control or what I prefer to call bed reassociation, sleep restriction, or as I prefer to call it, sleep consolidation, relaxation training. Those last three that I just mentioned are standard recommendations for improving sleep that are effective by themselves as monotherapies. Behavioral sleep medicine also includes cognitive therapy, changing the unhelpful thoughts that can interfere with sleep. It does include sleep hygiene. It also includes circadian strategies, which are augmentation strategies like light therapy and melatonin. And it definitely addresses sleep in the context of sleep, medical, and psychiatric comorbidities. So as you can see, there are multiple components to behavioral sleep medicine, each of which can be individualized, so it can be very tailored to the patient. And it actually helps people who are having sleep problems in the context of various comorbidities either improve their sleep or resolve their sleep problems. The usual targets for behavioral sleep medicine are threefold: the circadian system, the sleep drive, and that hyperarousal response. When these are optimized, I always tell people, even if these are optimized, it's not going to guarantee that you'll sleep well. There's really nothing that can guarantee sleep except staying awake long enough. But if your circadian system, your sleep drive, your hyperarousal response are optimized, it makes it more likely that sleep will unfold. We'll talk about each of these systems in more detail as we go along. So let's focus first on sleep duration. I like people to understand something they normally don't. I can't tell you how many patients I see who come in and insist they need 8 hours of sleep. That is often neither accurate nor helpful. There's normal variability in sleep duration, which is partly genetic, 40% genetic, based on family and twin studies. So I always encourage people not to get too attached to a particular number, because quite frankly, when I see people for the first time, they usually have no idea what their natural sleep duration is, not only because it varies between individuals, but because it changes as we get older. In addition to which, even though there are guidelines for how much sleep we should be getting, these guidelines are imperfect. This is a chart put out by the National Sleep Foundation in 2015, based on a review of hundreds of articles by sleep experts who convened and achieved consensus on what the recommended sleep duration should be. Unfortunately, almost all the studies relied on retrospective self-report of sleep duration, which is notoriously inaccurate. The studies use different standards for defining short sleep versus long sleep versus the reference sleep group. And so these guidelines need to be taken with a grain of salt. As always, whenever we're doing research or examining evidence, the phenomenon we study are far more complex than we usually understand, and the ways we try to measure those phenomenon are often more limited than we'd like to believe. So it's important to recognize this and not take this as gospel. Usually it's also important to understand that the informal definition of sleep for an adult, of good sleep for an adult, is less than 30 minutes to fall asleep, less than 30 minutes awake at night, which means you can be awake for almost an hour at night and still be considered to get good sleep. The way to interpret this chart, you can see total sleep time goes down as we get older. The largest age group here, the 26 to 64-year-old adults. The dark blue rectangle in the center, those are what I call the average sleepers, the ones who arguably need to get 7 to 9 hours of sleep or need to spend 7 to 9 hours in bed as long as they're sleeping most of that time. Underneath are the short sleepers, the ones who need 6 hours of sleep. Above the long sleepers, the ones who need 10 hours of sleep. All normal sleep, as I said, 50% genetic. Again, it's important not to get too attached to the number that's bandied about, the 8 hours that everyone is supposed to need, because that, like I said, may not be accurate, may not be helpful. So how do you determine how much time to spend in bed? Well, there may be some experimentation involved. Oftentimes, almost always, my guess is that most, if not all of you, are probably engaging in some behaviors that are interfering a bit with sleep. And so it might require some experimentation with changing some of the behaviors, changing some of the thoughts that are making sleep worse than it would otherwise be. So part of it is experimenting. I do want to emphasize, though, when you latch onto the wrong number of hours that you believe you need to sleep, this can get you in trouble. So let's take an example. Insufficient sleep duration would be someone who naturally needs 6.5 hours of sleep, but is only spending 4.5 hours in bed. They actually need to spend more time in bed. But if you are someone who needs 6.5 hours of sleep, but believe you need 8, so you're spending 8.5 hours in bed, you're guaranteeing yourself that you're going to be awake for 2 hours at night. You're essentially creating insomnia. And this is the problem I see over and over when people come in thinking they need 8 hours of sleep. By the time we're done with treatment, they actually are getting less sleep than that and feeling better as a result because the sleep quality is better. So part of figuring out how much time you need to spend in bed is recognizing that there's normal variability in sleep duration between individuals, that you don't want to turn sleep into a performance by getting attached to a particular number and trying to achieve it, because that will backfire. But the other thing you can do to maximize or increase the likelihood that you will get the amount of sleep, the sleep duration that you need, is by maximizing your sleep drive. So sleep drive is a biological drive that works very much like hunger. With hunger, of course, the longer you go without sleeping, the hungrier you get. Sleep is similar. The longer you go without sleeping, the longer you go without eating, the hungrier you get. The longer you go without sleeping, the sleepier you get. You can maximize your sleep drive in several ways. First, by avoiding or limiting napping. Now, there are genetic differences in our ability to nap. Some people cannot nap at all. Other people, if they nap, will sleep for 3 hours, feel awful when they wake up. Napping is not a good idea for them. But some people can do that 10, 20-minute power nap. So if that works for you, that duration of napping will not interfere with sleep as long as you're taking that nap 7 to 9 hours before your bedtime. You can also stay awake longer, which means spend less time in bed, because again, the longer you're awake, the greater that sleep pressure, and the greater the sleep pressure, the faster you'll fall asleep, the faster you'll get back to sleep. And finally, you can increase physical activity. Physical activity is one of the best ways to build sleep drive, especially cardiovascular activity. So you can optimize your sleep duration or make it more likely you'll get the optimal amount of sleep you need by figuring out the right number for you, spending the appropriate amount of time in bed, and maximizing your sleep drive. There's one other point that I like to emphasize, especially to people who are using sleep aids. This little molecule, adenosine, this is the molecule that builds along with sleep drive and comes down as we sleep. It's the molecule most closely associated with sleep, especially deep sleep. And adenosine, as you all know, results from energy expenditure. So if you're expending energy, if you're awake and active, you are building adenosine. If you're building adenosine, you're building sleep drive. If you're building sleep drive, at some point you're going to fall asleep. You can't actually break that system until you die, and there's no medication that produces adenosine. So these are the things I'd like to emphasize when it comes to sleep duration. Let's move on now to sleep timing. Oops. So sleep timing, 50% genetic, normal variability in when we naturally feel sleepy or when we naturally feel awake. There are larks and hummingbirds and owls. And most people, 65% are probably hummingbirds, so those who naturally feel sleepy at 10 or 11, naturally awake at 6 or 7. Morning larks feel sleepy a lot earlier, usually 6 to 8 in the evening, but they're awake a lot earlier, 2 to 4 in the morning. And night owls will feel sleepy a lot later. Most common bedtime I see is 1 to 2 a.m., most common rise time, 9 to 10 a.m. Again, all normal sleep. The recipe here for better sleep is to sleep according to your chronotype, whether you're a lark, a hummingbird, or an owl. We tend to get our best sleep in the window that fits with our body clock. Now, this is a challenge, at least in our culture, especially for night owls. Remember those cultural norms that are part of the biopsychosocial model. We are more of a morning culture, the expectation being everyone will be awake and alert at 7 a.m., which is profoundly unfair and frankly discriminatory toward night owls. In other cultures, European, North African, the expectation is people won't be going to bed until 1 or 2. So they're later cultures, more evening cultures, and the morning larks might struggle in those cultures. But ideally, you want to sleep according to your chronotype. Now, how do you figure out what your sleep timing is? Well, this is where that second system, remember we talked about sleep drive a moment ago. Now we're going to talk about the circadian wake drive. This is where that second system comes in. So as your sleep drive is building, as you are getting sleepier across the day, you are not falling asleep throughout the day, hopefully. If you are, we'll talk about that in the context of daytime alertness, but hopefully you're not falling asleep throughout the day. And why is that? Because even as the sleep pressure builds, that circadian wake drive sends out alerting cues to keep you awake. Things like physical activity, social activity, mental activity, light exposure, all of these things help us overcome the growing sleep pressure across the day. Now, it's important to recognize, you can see the alerting signals increasing as sleep pressure goes up. Here is where the forbidden zone starts. This is the period of maximum alertness in these cues. Immediately after this period, the sleep gate opens. This is when the alerting cues start to drop off and your sleep pressure is high. This is what we all want to look for, that sleep gate. The problem is people get in trouble in this forbidden zone because the alerting cues are so high. So they'll often experience a surge of activation an hour, 2 hours before bedtime, at which point they may start projects or do things that they had intended to do earlier but didn't have a chance to, and they might keep themselves stimulated well past the sleep gate. So part of figuring out the right timing for your sleep is making sure you do the right things that allow you to capture the sleep gate and not miss it. What are those things? Well, I suspect you all know what I'm going to tell you. Get off your screens, especially in the hour before bedtime. Now, why is this important? Because what needs to happen in the evening before sleep, in order for sleep to occur, several things. Number one, your melatonin has to go up. That's this blue line. Our melatonin typically goes up naturally within an hour and a half or 2 hours of our bedtime. So we need our melatonin going up. Conversely, we need our cortisol going down. Cortisol is usually at its highest point in the morning and then drops across the day, continues to drop toward evening, which is important since cortisol is a stress hormone, and when we are stressed, we are not going to be sleeping. And finally, our body temperature has to go down. One of the big cues, the two biggest cues, evolutionarily speaking, for sleep were light to dark and warm to cool. So we typically will start to feel sleepy as our body temperature drops. Guess what? When you're on your screens, none of this is happening. The blue light from screens, that enriched blue light, suppresses and delays your melatonin. It keeps your cortisol high, along with your dopamine, both of which, whether stress hormone or reward hormone, both of which will keep you alert, and it prevents your body temperature from going down. So if you're on your screens at night, everything you need to help you transition into sleep is not happening. And that is why creating a no screen pre-bedtime buffer zone in that hour before bedtime is one of the most effective things you can do for your sleep. I remember working with one patient. This is a very hard thing to do. Most people struggle with this. I remember working with one patient. The first session, we talked about this. She put in place a 2-hour wind down routine. By the second session, she was done. Her sleep was fine. I'm not saying it's going to work that way for all of you, but it can be incredibly powerful to literally stop your screens in that hour before bedtime. Let's move on to sleep regularity. This is a really interesting area of increasing interest in sleep research. There are various ways of thinking about sleep regularity. One of the most common to date has been what's called social jet lag, the difference between sleep on work or school days versus sleep on free days. But there are other ways of thinking about it. So in example B, we've got irregularity in both sleep duration and sleep timing. In example E, we have irregularity of sleep periods across the 24 hours. So this person is taking naps. In example F, we have irregularity of wakefulness at night. So there's wakefulness happening across the night, but at different times. And in example G, we have irregularity of sleep periods across the weeks. So you can see this is someone who is doing all-nighters. You can see these blank spaces mean they were awake all night. There are different ways of measuring sleep regularity. The most common, again, to date has been the social jet lag, where you look at the standard deviation of the average midpoint between the sleep on work or school days versus sleep on free days. So there's going to be a difference. Usually people are going to bed earlier, trying to get up earlier on work or school days, and then going to bed later, getting up later on free days, often weekends. You can also look at the variance in a 24-hour sleep pattern compared to overall variance across the week. And the more recent measure of sleep regularity, what's called the Sleep Regularity Index, actually compares the sleep-wake pattern across each 24-hour period in comparison to the next. So it's a time series analysis. When people have started looking at the social jet lag or sleep regularity index, they've come up with some interesting correlations in recent research. So the more irregular the sleep, the greater the risk for lower mood and well-being, poorer cognitive functioning, impaired daytime performance, obesity and inflammation, poorer cardiometabolic health, higher all-cause mortality. There's some people who are doing research in this space who actually suggest that sleep regularity may be a more important predictor of certain outcomes than sleep duration. And I think sleep regularity is often ignored. People overfocus on the amount of sleep they're getting. They will sometimes struggle with the timing of sleep, especially the night owls, but people generally ignore the importance of how regular or consistent their sleep schedule is. So what does this mean as an actionable item? Well, ideally, it means you sleep in a very consistent schedule. Now, this is an impossible ideal that I've shown here, but you at least want to keep in mind that a sleep schedule that is as regular as you can make it helps to establish a very robust circadian sleep-wake rhythm, which reinforces that regularity. It certainly seems to be helpful as far as certain outcomes, the ones we just talked about. The other thing to keep in mind is that circadian system regulates not only our sleep-wake patterns, but also our feeding, fasting patterns, our rest activity patterns, our light-dark exposure. And there is some interesting research being done looking at regularity in meal timing, light exposure, social activities. One of the recent articles that I've cited here, the Hand and colleagues article in 2023, actually showed that people with more regular sleep schedules had more regular light exposure. And the converse, people with more irregular sleep schedules had more irregular light exposure. My guess is, given the importance of the circadian system to our overall health, that consistency in some key circadian rhythms and circadian zeitgebers like light and meal timing activity is going to be important. So not just consistency in sleep, but consistency in these other things because they are mutually reinforcing. What about sleep efficiency? So sleep efficiency is your total time asleep compared to your total time in bed. Now, good sleep efficiency for an adult is considered to be 85% or higher. So 85% of the time you're in bed, you're sleeping. Usually it's 85 to 95%. No adult gets 100%. Those days are reserved for when you were much younger. Insomnia, to me, is the classic example of inefficient sleep. People with insomnia are having trouble falling asleep, staying asleep, or they're waking up early, unable to get back to sleep. So they're spending time awake at night. Chronic insomnia, it has to be occurring often enough or going on long enough to qualify. It has to be occurring despite adequate opportunity and circumstances to sleep. And it does, like every disorder, it's a 24-hour disorder. It has to be associated with some sort of perceived distress or impairment during the day. So insomnia is a classic example of inefficient sleep. Well, what do you do about insomnia? How do you create more efficient sleep? This is where one of the counterintuitive techniques comes in, one of these behavioral sleep medicine techniques that no one would ever think of on their own. It's called sleep restriction. I prefer sleep consolidation because you're not actually restricting the amount of sleep someone gets. You are limiting their opportunity for sleep so that you can consolidate it. This picture here shows what sleep consolidation, how it works, what it looks like. So it across the bottom here, pre-insomnia, so no insomnia here, then acute onset of insomnia, early stages, more chronic stages, and then the start of this sleep consolidation treatment. The red is total time asleep, the blue is total time in bed. Here, when someone does not have insomnia, their sleep efficiency is good, 85% or higher. Most of the time they're in bed, they're sleeping. Here, there is some sort of stressor. Stress always disrupts sleep. So some sort of stressor comes along, disrupts sleep, they start sleeping less. Initially, they don't worry, but at a certain point, they start to worry and they start to think, oh, I'm not sleeping well. Maybe I'll go to bed a little earlier tonight. Maybe I'll sleep a little later tomorrow. Maybe I'll try to take a nap later today. So they start to increase their time in bed. And as they do so, their sleep gets worse. Why? Well, first of all, they're spending more time in bed doing nothing. So their sleep drive is lower because your sleep drive is higher when you're awake and active and out of bed. So sleep drive is lower. Number two, what do we usually do when we're awake at night? Worry about being awake, getting back to sleep, what we're going to do the next day, or hundreds of other things. Worry is the common activity in which we engage, and that's just going to keep us awake longer. And finally, when we're spending, as this person is in the chronic stages of insomnia, half the night or more awake, we're teaching ourselves that the bed isn't for sleep. It's for lying awake and worrying, none of which helps sleep. So this is why the more time people spend in bed, the worse for their sleep, as long as it's not an insufficient sleep duration problem. Then you do need to spend more time in bed. But if it's an insomnia problem, you actually need to spend less time in bed because the more time you add to your time in bed, the worse for your sleep. The only thing to do is remove all the wakefulness, shorten your sleep opportunity, shorten that time in bed, drive up your sleep pressure, and start to consolidate your sleep, fill in that wakefulness. And that's what we do. This is a very difficult technique to implement. And usually when we first do it, people freak out because they're now allowed a much shorter time in bed and they worry they won't get enough sleep. But if they stick with it, their sleep quality will improve and their sleep efficiency will normalize within 2 to 3 weeks. And if it hasn't, then either they're not doing it or there's something else going on. And so usually we shorten the sleep window. Initially, the first, 2-3 nights are not good because they're so anxious, but inevitably sleep drive kicks in if they stick with it. Sleep starts to increase until after 2 or 3 weeks, they're back to 85% or higher sleep efficiency. And at that point, we start to increase the time in bed until we hit the balance between good quality sleep and sufficient quantity sleep. So this is how sleep consolidation works for insomnia, a very, very counterintuitive technique. And this is where that instruction to spend less time in bed comes in. Again, no one who is getting poor sleep will ever think to themselves, maybe I should spend less time in bed rather than more time in bed. And this is why the behavioral sleep medicine approach is so helpful, because it helps people understand why that behavior, spending more time in bed, is actually making their sleep worse. So that's efficient sleep. Now, what about sleep satisfaction? This is trickier because sleep satisfaction is a very subjective perception of sleep that can be influenced by many, many things. The biggest thing that influences sleep satisfaction is anxiety about sleep, and insomnia is anxiety about sleep. People with insomnia are not satisfied with their sleep ever, and they attribute everything to sleep, not just being awake at night, but how they function the next day, their enjoyment of life, other factors that might be contributing. So this anxiety about sleep makes sleep worse. If you're anxious about sleep, you're not going to be sleeping as well. So how do you address this anxiety about sleep? This is where the cognitive therapy comes in and the relaxation therapy. We've talked about that sleep consolidation. We just talked about that. We'll talk more about the bed reassociation in a moment, but here what we're focusing on is the cognitive components and the relaxation components of behavioral sleep medicine. So how do we address these cognitive components, these unhelpful thoughts, these misconceptions about sleep, these unrealistic expectations? Well, we go over a lot of common sleep myths. So one of the first myths, I must get 8 hours of sleep to function the next day. You now know that's not true, since there's normal genetic variability in sleep duration. Not everyone needs 8 hours of sleep, but even if you were someone who happened to need 8 hours of sleep, that was the appropriate sleep duration for you, what happens if you get 6 or 7 hours on one night? Will you not be able to function the next day? Will you spend the whole next day in bed? No one I've ever spoken with, of the thousands of patients I've seen, has ever done that. We are evolutionarily designed to deal with less sleep than we might need on some nights. So this belief, I have to get 8 hours, otherwise I can't function. Imagine what's happening if you're lying awake at night thinking this. I need to get back to sleep now, otherwise I won't get my 8 hours and tomorrow will be a disaster. You are not getting back to sleep anytime soon. So this is a common myth, very unhelpful. What about this next one? If I've had good sleep, I should wake up feeling refreshed. Actually, not necessarily true. There is a phenomenon called sleep inertia, which describes normal morning grogginess that occurs as melatonin leaves your system. When melatonin is in your system, you will feel groggy, low energy, low mood. Once you're up and moving around, that grogginess will dispel, usually within 20-30 minutes. Night owls, it tends to take a little longer. The fastest way to dispel it is light and activity to increase your body temperature. I mentioned that in the evening, you want your melatonin going up, cortisol and body temperature going down. In the morning, exactly the opposite. You want melatonin going down, cortisol and body temperature going up. Fastest way to do that, get outdoor light exposure, physical activity. Those are the two best ways to feel more refreshed or more alert more quickly. The worst thing to do is linger in bed and hit the snooze button. That'll just prolong the grogginess. So you never want to base your assessment of how you slept and how you feel the moment you wake up. That's misleading. You want to look instead at how you're feeling and functioning during the day. The right amount of sleep for any one individual is the amount that allows them to feel alert and well rested during the day, apart from a bit of morning grogginess, a dip in the afternoon, and some sleepiness toward bedtime. That's how you know you're getting the right amount of sleep. What about this next one? I wake up a couple times each night, fall back to sleep pretty quickly, but it can't be good for my sleep. Well, guess what? On average, adults wake up 10 to 12 times a night. Most of the times they don't remember, because if you're awake for less than 3 minutes, you will not remember, which is why you can literally have a conversation with your bed partner in the middle of the night and not remember it at all. So waking up at night is normal for adults. We might remember none of those or one of those or two of those, but if we're falling back asleep quickly, remember, normal sleep, less than 30 minutes to fall asleep, less than 30 minutes awake at night. So we're falling back asleep quickly. This is normal. And once again, what happens if you're someone who's thinking, I need 8 hours, I should sleep through the night, I should wake up refreshed? You will never be satisfied with your sleep if you're someone who doesn't need 8 hours and you don't understand that these are common myths. What about this next one? If I spend more time in bed, I'll get more sleep, feel better the next day. You now know that for someone with insomnia, that's exactly the wrong thing to do. You actually need to spend less time in bed to get better sleep and feel better the next day. For someone with insufficient sleep, that person who's spending 4.5 hours in bed despite actually needing 6.5 hours of sleep, yes, you spend more time in bed because you will get more sleep and feel better the next day. What about this next one? I need to try harder to sleep or to make up for lost sleep. Sleep is not a performance. If I tell all of you to go home tonight, make sure you get 9 hours of sleep, the vast majority of you are going to fail that assignment because you likely don't need 9 hours of sleep. You can't force yourself to sleep more than your body needs. And as soon as you try to turn sleep into a performance, you're going to get more activated and you're going to guarantee you're going to be awake longer. This is why I have a mixed response to people tracking their sleep. It's not like you can use the tracker to increase your sleep duration the same way you can increase your steps during the day. And it can actually create what's called orthosomnia, this effort to achieve this idealized version of sleep that actually can make sleep worse. My sleep system is broken and cannot be fixed. I always tell people when, and I also see this belief for people who are using sleep aids. So I always tell people, if your sleep system were truly broken, if we're not producing sleep, you die within 2 weeks. So your sleep system is producing sleep. And remember, you're building your sleep drive all by yourself. The sleep aid isn't doing it. Now, I will say there are some rare exceptions to this, usually neurodegenerative conditions, the most obvious being fatal familial insomnia, a very, very rare condition, a prion disease, in which sleep centers in the brain, as well as many other areas of the brain, gradually deteriorate, making it more and more difficult to sleep. And that does have, I mean, usually the mortality, people will die within 6 months to 2 years when they have that condition. But I am never going to see someone whose sleep system is truly broken. Usually it's the things that people are doing, the things that people are thinking that are getting in the way of their sleep. This next one, if I don't get enough sleep, I need to cut back on what I do the next day because I don't have enough energy. This reflects a very unhelpful and mistaken belief that energy is a finite resource and it all depends on how much we sleep. In fact, remember, it's not just our sleep drive, it's our circadian system. And even if we don't get as much sleep as we might need or like, that circadian system, because of the alerting cues, helps us feel more awake at different times. And so, and the other misconception is that all activities deplete energy. Actually, there's some activities, social activity, physical activity, that increase energy. The worst thing to do after a night of poor sleep is cut back on your activities because you actually drop your sleep drive and you make it more likely sleep is not going to be as good that night. So even after a poor night of sleep, go through your day the way you normally would. When we get poor sleep one night, the sleep system is naturally self-correcting. We usually get better sleep the next night, unless we try to outwit Mother Nature by correcting it ourselves, sleeping in later the next day, trying to nap, cutting back on activities. All of that will make sleep worse. So just didn't get a night of great sleep, go through your day the way you normally would, just expect sleep will be better the next night. And finally, there's nothing I can do to manage my sleep or the consequences of inadequate sleep except take a pill. If you have restless legs or narcolepsy, yes, medication is very important to manage that. If you have insomnia, no, you do not need to be on sleep aids. In fact, every sleep aid will change your normal sleep pattern. Sedation is not sleep. And sleep aids are not producing your sleep drive. You are, again, producing that all on your own. If you change some other behaviors, that will allow your sleep drive to unfold more easily. So sleep aids change normal sleep patterns. They don't give you, sort of the typical pattern of deeper and later stages of sleep, REM sleep. In addition to which, sleep aids, there's no sleep aid, prescription sleep aid, that is strongly endorsed by the FDA for use with sleep, for insomnia, the recommendation is cognitive behavioral therapy for insomnia, changing the unhelpful behaviors, changing the unhelpful thoughts that interfere with sleep. Any medication that is weekly endorsed is supposed to be used for no more than 4 to 6 weeks. This is in part because sleep aids, what the research shows, they give you an extra 10 to 20 minutes of sleep, usually. So there's very little upside to taking a sleep aid if you have insomnia. And there's a huge downside because there are problematic effects in the short term and increasing concern about problematic effects in the long term, like cognitive decline. The reality is, if you leverage your sleep biology, the sleep and circadian systems we talked about, the sleep drive, circadian system, that hyperarousal response, that is what will allow you to get better sleep. And that is far more powerful because Mother Nature has had millennia to refine these responses. So we always address these common sleep myths. We also encourage, as a way to distract people from the anxious thinking that can occur at night and enhance the relaxation that's so necessary for sleep, we encourage them to practice and engage in regular parasympathetic relaxation. For sleep to happen, we have to shift from a sympathetic stressed state to a parasympathetic relaxed state. We're naturally in that state when we sleep, but if you can facilitate that in that hour or so before bedtime, it makes the transition to sleep easier, and it also makes falling back asleep if you wake up at night easier. The nice thing about these relaxation exercises, diaphragmatic breathing, progressive muscle relaxation, guided visualization, body scan, those first 4 you can do before you get into bed, once you're in bed, if you're awake at night. So that's good because it will help with sleep. You can also use these during the day because stress itself, as I mentioned before, will always disrupt sleep. The better you are at managing your stress, or the less reactive you are to stress, the better it's going to be for your sleep. And these things will help reduce stress, not just at night, but also during the day. And finally, you do want to make sure that your bed is strongly, clearly associated with relaxation, sleep, and sleepiness. Problem is, if you're having trouble sleeping, number one, people often get into bed early, or if they're awake at night, lie awake for a bit, and they'll engage in wakeful activities. They might watch TV or pick up their phone or read a book. So now the association between bed and sleep is getting weakened because bed is associated not just with sleep, but with wakeful activities. Even worse, if you have insomnia or trouble sleeping, you'll start to worry about sleep. And now when you get into bed, you will become more activated and anxious rather than more relaxed. So the bed is not associated with relaxation and sleep. It's associated with activation and wakefulness. All of that makes sleep worse. The classic example of this is someone who is sitting on the couch in the living room watching TV and falling asleep, and they stand up, walk into the bedroom, lie down in bed, and they're wide awake. That is because when they're watching TV, they're not focusing on sleep. They're not trying to sleep. In fact, they're trying to stay awake so that they can finish their show. And all of that, because their sleep drive is high and they're relaxed and they're not actively trying to sleep, all of that means they'll fall asleep. Sleep drive is high, you relax, that's how sleep unfolds. Once they get into bed, all of a sudden they're anxious about sleep, they're more activated, they're now trying to sleep. That means they're going to be awake, and that's why they pop awake when they lie down in bed. So the classic instructions for this stimulus control, as it's called, or as I prefer to call it, bed reassociation, you go to bed when you're sleepy, and we'll talk about the distinction between sleepy and tired in a moment, but you go to bed when you're sleepy, you get up at the same time every day. Let's say you had a night of poor sleep, you get up at the same time. No, despite that, your sleep drive is going to be higher the next night, and you'll get better sleep the next night. That's that self-correcting aspect of the sleep system. If you happen to be awake for what feels like more than 20 minutes, you get out of bed, don't check the time. Checking the time stresses us out. I definitely have everyone I work with do this, and that intervention alone either has a small beneficial effect on sleep, or that is the main thing someone needed to do to get better sleep. So you get out of bed after what feels like 20 minutes because you happen to be awake in that moment. So if you doesn't feel like you're getting back to sleep right away, get out of bed and just be awake for a bit in a calm and enjoyable way for what feels like 30 minutes before going back to bed. That ensures that your bed remains associated with sleep. It's usually easier to fall back asleep if you do that. You do all your wakeful activities outside of the bed and use the bed and bedroom only for sleep and sex. And when you do this over and over again, the repetition is basically a form of Pavlovian conditioning, classical conditioning. You are training your brain and body to associate the bed with sleep, just like a dog might associate a leash with a walk. And you literally can teach yourself to be excited about sleep when you see that bed. So these are all the things you can do to decrease anxiety about sleep, and enhance that satisfaction that comes with a more realistic understanding of how sleep works and what you need to do to optimize it. Now, finally, let's talk about this daytime alertness. This really reflects the extent to which you're sleepy or alert during the day. There are several things to understand about this. First, insomnia does not equal sleep loss. Sleep loss is when you're perfectly able to sleep. So there's nothing wrong with your sleep ability, but there's something interfering with your sleep opportunity. Classic example, you're up taking care of a new baby, right? If you were in bed, the baby weren't there, you would be sleeping. Or maybe you have to be up for some work project or up early to perform surgery. If you were in bed, you would be sleeping. In all these cases, you're losing sleep. Sometimes it's medical conditions like untreated sleep apnea. Your body is trying to sleep, but an apneic event comes along and wakes you up or puts you into a lighter stage of sleep, what we call microarousal. In all these cases, you're losing sleep. And the most common consequences of this is you feel sleepy during the day. You are not feeling alert during the day. Sometimes it will manifest as falling asleep in meetings or making careless mistakes or dozing off at your computer. You definitely want to address that sleep loss. There's almost always some underlying cause to daytime sleepiness. Now again, there's a normal dip in the afternoon. So in the afternoon, sometime between 12 and 6, depending on our chronotype, our body temperature drops, so those circadian alerting cues go down. We've built up some sleep pressure at that point, so it's very common to feel tired or sleepy in the afternoon. Nothing wrong with that. It will pass. But if you're feeling sleepy at different times throughout the day, that is when you want to look at possible causes of sleep loss and get those addressed. Now, insomnia is different. Insomnia, there's nothing interfering with your sleep opportunity. There's no new baby. There's no work project, no untreated apnea, but you're in bed awake. Why this happens? Probably various reasons. Number one, people are more anxious and activated about sleep, and so that's keeping them awake. Number two, they might be spending too long in bed, so they don't have enough sleep drive to carry them through the night, so that's keeping them awake. Interestingly, though, whereas the classic phenotype for sleep loss is what I call dozy and dopey, the classic phenotype for insomnia is tired but wired. People do not fall asleep during the day. They actually function okay during the day. You still want to treat the insomnia. What's interesting is when we think about daytime alertness, sleep loss leads to reduced daytime alertness. Insomnia leads to increased hyperarousal. And that is like they're more alert, but almost too alert. And this is where, when we go back to the techniques I was talking about before, the relaxation, correcting the common myths, this can actually help reduce that hyperarousal. The other distinction to consider is the difference between sleepiness and fatigue. Sleepiness is the propensity to fall asleep, usually driven by a higher sleep drive, sometimes sedating medication, sometimes cold, flu, or other illness. Fatigue is different. Fatigue is feeling physically or mentally depleted, exhausted, and there are so many reasons other than sleep that can contribute to fatigue. Getting too much or too little physical activity, being stressed or anxious or depressed, being bored, being on screens all day, so you get that eye strain, being hungover from alcohol or crashing from caffeine, having low hormone or vitamin levels, circadian effects, jet lag, delayed sleep phase where you're not able to sleep according to your chronotype, certain infections, certain medical or psychiatric conditions, medication side effects. The reason this distinction is important is twofold. Number one, oftentimes when people mistake these two things, they will get into bed when they're tired, but not when they're sleepy. That sleep gate is when you're sleepy. If you get into bed 2 hours before the sleep gate, you are not going to fall asleep. You're getting into bed when you're tired, but not when you're sleepy. So you want to get into bed when you're sleepy. The second thing is there are so many reasons that can contribute to fatigue. And if all of your efforts and attention are focused on sleep, you will miss those other reasons and you will not address them properly. So you want to be clear about this distinction. The final thing about alertness, daytime alertness, insomnia is associated with multiple comorbidities. So insomnia is common with pretty much all sleep disorders, obstructive sleep apnea, restless leg syndrome, periodic limb movement, circadian rhythm disorders, nightmares. It's common with a lot of medical conditions, chronic pain, migraines, allergies, asthma, reflux, irritable bowel, nocturia, heart disease, hypertension, diabetes, hypothyroidism, traumatic brain injury, Parkinson's, and pretty much every psychiatric disorder, anxiety, depression, bipolar, post-traumatic stress disorder, eating disorders, substance use, neurodevelopmental disorders. So because insomnia is such a large bucket, it captures so many other comorbid conditions. You want to consider seeing a sleep specialist if you have tried different things to help with sleep and it's not getting better. Because almost certainly there's probably something else underlying that insomnia. So that addresses the daytime alertness. What I love about behavioral sleep medicine and its focus on sleep health, including these 6 dimensions, is it really is a gateway therapy. No one who is sleeping poorly, if asked, do you want to get better sleep, will say no. Everyone who's sleeping poorly wants better sleep. In addition to which, people often perceive sleep as something extrinsic to themselves. The problems they're having with sleep are not their fault. Something outside them that's happening, so they're more willing to make the changes needed to get better sleep. Whereas if people experience something more like depression or anxiety, it feels more intrinsic to themselves, it could be harder to make those changes. So I'm hoping that you were able to get some useful information for your patients or maybe others you know who are having sleep problems, or even for yourself from this talk, and I am happy to take questions. Thanks so much for your time and attention.
Dr. Barwick, thank you. That was amazing. By 8:30, I think we hit a record for the number of questions we have already. We were joking about that before. I didn't know if there's going to be no questions or just an insane amount of questions given the topic, and I think we know now. I want to get into it immediately to get as much time. So, and please, everybody, if you're asking questions, please put more in. We'll try to get through as many as we can, but do upvote so we can get to the ones that are the most popular. Dr. Bonilla asks, great question. Our society where the quote unquote siesta is part of culture, do they have more or less sleep disorders, and do they need more sleep medicine, like in Spain, for example?
Yeah, well, interestingly, the rates of insomnia are pretty consistent across cultures. In Asia, there are some studies showing lower rates, but the folks I know who are working in Asia, there are very few. They are very clear that many, many people have sleep problems, and there's a huge need for behavioral sleep medicine and sleep specialists in general in pretty much every country. And I do think there's a sort of paradoxical effect of the focus on sleep, which is helpful. It has been helpful in correcting the historical disregard for sleep that occurs in many cultures, but I think the pendulum can tip a little far in the other direction and increase anxiety about getting the right amount of sleep, and when combined with these misconceptions can actually lead to insomnia. So no, the rate of the percentage of, or the incidence of sleep disorders, incidence and prevalence of sleep disorders is pretty consistent across cultures. So I think behavioral sleep medicine is an important component for every culture, as long as you take the cultural norms into account.
Dr. Yen asked this question, and you did touch on it about sleep depth. Can you catch up on sleep later? Is there a depth? Can you touch on more? Is there a depth to be back 5 hours in the weekday and then 10 hours on Saturday?
You know, you can catch up on a certain amount of sleep. It usually takes giving yourself an extended sleep period over the next 2 to 4 days. I think the challenge here is twofold. Number one, so different functions will recover at different rates. The first thing to recover is your perception of performing normally. So you will believe you're performing normally before you actually do, like back to your usual level. So that, and then like cognitive functions, physical functions recover at different rates. There's some functions that don't seem to recover for 9 days. So that's problem number one. And it's not clear you can make up all the sleep. It's almost certain you can't make up all the sleep debt. The problem number two is if you're trying to make up sleep debt on the weekends, you're now engaging in social jet lag. And we just talked about the importance of regularity in your sleep schedule. So you're now having a more irregular sleep schedule with potentially problematic consequences.
Dr. Klein asks, and I might tackle a little, this is a great question though, what activities should be encouraged or suggested during the no screen hour before bed? Can I also add in, a lot of screens have locks or different apps where you can take away the red light. I have like 3 of them on my phone because I'm staring at my phone to go sleep. So what should be done if you're not looking at the screen, but also can I also tack on, do those apps allow you to use screen a little bit more?
No, the short answer, no. So in order to block the blue light, you have to block 99.9% of blue light. Everything should look distinctly orange, not yellow, not that pale yellow that you see with some of the night shift settings. It should look distinctly orange. Even if you're able to block the blue light, you're not blocking the content, and the content is increasing your cortisol, your dopamine, and your body temperature. The reality is you've been on your screens all day and most of the evening, usually. And so letting go of the screens, I mean, I get that we all have this, as Dr. Lemke and the Dual Addiction Clinic describes it, the digital dopamine addiction. But kicking that addiction the hour before bedtime is really going to be one of the most helpful things you can do. So what do you replace it with? This is where you have to get creative. So reading a book or magazine, listening to music, practicing a hobby, doing some puzzles, spending time with loved ones, grooming your pet, doing some gentle stretching, taking a leisurely stroll. There are many, many things, organizing, doing a couple of minor household chores or organizational tasks, nothing too stressful, nothing too stimulating. If you do read a book, you don't want a page turner, something you're going to want to finish, spend hours finishing. Anything that enhances relaxation, enhances a positive emotional state, all of that is great. The reality is we fall asleep most easily, whether we are 8 years old or 88 years old, when we feel safe and comfortable and relaxed and loved. That is the state you're trying to create.
There's a question asked later I might tack on as well. Is TV considered the screen?
Yes, it is. It's the least problematic. Your phone is probably most problematic because it's closest to your face. The TV is further away, and the impact of light is halved exponentially. So it is less problematic, but once again, you have to consider the content. So some TV is appropriate, and everyone's a little different. I've certainly known people who use, they would watch sitcoms that they'd seen lots of times before. They found it comforting. That seems very appropriate, or something a little lighter that makes you laugh, especially if you're watching it with, someone you love, a partner, a family member. So all of that, I think, is okay. TV is the least problematic of the screens.
I want to ask you about sleep aids. You talked a lot about that, and that's really helpful, particularly as clinicians. There's a few questions I'd like to put together that touch on sleep aids. One is from Dr. Razavani. What is the appropriate use of melatonin? I have several patients who take it chronically. Should this be discouraged? Does it even work? Dr. Golden asks, when do you recommend using Ambien? Again, you talked about sleep aids in general. I'm curious the different types. There's a big difference, of course, between Ambien and melatonin. Dr. Golden also asked about more natural sleep aids, perhaps. Do you recommend the use of banana, milk, or turkey to help get better sleep because of the serotonin and tryptophan?
So let's take melatonin first. Melatonin is tricky. The U.S. is one of the only countries where it's not regulated by the FDA based on research. Research has made it very clear. There's enormous variability between what's on the label and what's in the pill, anywhere from 87% less melatonin in the pill to 400% more. So you don't actually know what you're getting. If you are going to use melatonin, make sure it's pharmaceutical grade. Second problem, the amount of melatonin our circadian system, our pineal gland releases to help us feel sleepy is 1 picogram, 1/1,000,000th of a milligram. So think about the doses of melatonin that people take. It is way too much. So 1 milligram or around 1 milligram, less than 1 milligram, that would not be inappropriate as long as it's pharmaceutical grade. The research, however, about melatonin taken at bedtime it really shows very little beneficial effect. If you're using melatonin as not a sedative hypnotic, but a chronobiotic to shift the timing of your sleep earlier, if you're a night owl, that actually is effective. That is helpful. But that you're using a tiny dose, 0.5 milligram or less, 5 hours before bedtime. Totally different use. Taken at bedtime, very little benefit. I will say, however, that in Europe, where melatonin is a prescription sleep aid, it is often recommended for people over 55. There is some evidence that as we get older, there might be a slight drop for some people in melatonin. There are some neurodevelopmental conditions like autism spectrum where there seem to be abnormalities in melatonin synthesis. And so taking melatonin 3 milligrams 30 minutes before bedtime has proven useful. I mean, the studies are very clear that is helpful for sleep. It's possible. There are definitely some neurological conditions where there seem to be lower melatonin levels, and so experimenting with that could be useful. So I'm not averse to using melatonin. The side effects seem to be more minimal. Vivid dreams, occasionally headaches. So I'm not averse depending on the circumstances and what problems we're looking at. As far as Ambien, again, I am a proponent of people not using sleep aids or getting off sleep aids. It's a challenge, though, because behavioral sleep medicine specialists, it's hard training to acquire, and there aren't enough of us, and so people want relief. And so I get why sleep aids are prescribed, but what you want to do is, if you're going to prescribe a sleep aid, you want to make sure that the person understands this is not a long-term solution. There are problems that short-term and long-term that can occur when you're using it long-term. So let me not just prescribe you the Ambien, but let me also refer you to cognitive behavioral sleep medicine so that we can actually help you get better sleep that you can do sustainably over the long term, and we can get you off the medication. And finally, which was the third one? Oh, other supplements. There's not, unfortunately, the research is pretty inconsistent with other supplements. My basic philosophy on this, when it comes to supplements themselves, is as long as there's not contraindications, and for some, people often think if it's natural, it's good for you. Natural can kill you. So you want to be careful what supplements you're using. Something like kava kava, which has been recommended for sleep, it can increase liver toxicity, so you want to stay away from that. Something like valerian, chamomile, hops, lemon balm, sure, if you enjoy that as a tea, as a nice way to relax for bedtime, use it. As far as foods go, there are some foods that are naturally high in tryptophan or melatonin. Tryptophan, of course, being the precursor to serotonin, which is the precursor to melatonin. There's really no research that's been done on this, but generally, if you're following a Mediterranean diet, you are eating foods that are higher in tryptophan or melatonin, and it certainly can't hurt.
Do you mind if we go up maybe 5 after, or you have a
Yeah, that's fine.
great, thank you. I'll just get a few more. Dr. Lajani has a question. As a hospitalist, I was wondering this as well, and this is probably a whole nother conversation or presentation, but sleep approach disorder. So can you comment how you would approach sleep disorders in hospitalized patients? Completely different ballgame, of course, which is highly prevalent. We have behavioral strategies which are insufficient and not as effective to a number of factors. I always feel bad. We are always waking up our patients. They never sleep, maybe when they need it the most.
Yeah, that is such a challenge. And unfortunately, the best interventions would be systemic, organizational. And that's what some hospitals are doing, trying to do is they recognize the importance of sleep for recovery. So they're trying to create the equivalent of daylight during the day and sort of nighttime sleep with minimal interruptions at night. Really the only thing, so that would be optimal. Really the only, based on that sort of sleep drive circadian system, hyperarousal response, you would target the circadian system. You could conceivably do some of this individually by using a light box, which emits a high intensity light. So you could have them use a light box during the day, and then maybe have them use a sleep mask at night to block light cues. So you could try to create the appropriate light dark exposure. That would be targeting the circadian system. Sleep drive, having people, if possible, might not be possible, but taking a short walk around the corridors, doing a little stretching. Mostly though, you'd probably target the hyperarousal response, which is teaching them relaxation. Because that they can do anytime, anywhere. So that's probably the system I would target the most in hospitalized patients.
Dr. Schlichterman asks, what is your go-to question for patients to see whether they're getting restorative sleep? Is it not the amount, or if it is just awaken, refresh, not napping, daytime alertness? Like, what's your main question to really tease out what's going on with them?
It's not even a main question because there's so many misconceptions about sleep. It's just what I said before, that you're getting the right amount of sleep if you're feeling alert and well rested during the day, apart from a bit of morning grogginess, a dip in the afternoon, and some sleepiness toward bedtime. So oftentimes I'll see people who have this expectation they should feel wildly alert throughout the day. No, that's actually not true. They should feel refreshed when they wake up in the morning. No, that's not true. And so that's usually what I tell people. We have a lot of questions we ask when we see people for initial evaluation, because there's so many factors, behavioral, cognitive, lifestyle, that can affect sleep. So I wish I was able to give you that sort of one statement question. I just don't have one.
No, that's helpful. Carrie, one of our nurse practitioners, she mentions she's a patient at the Stanford Sleep Clinic receiving CBT from Stanford. Thank you for sharing that. I'm also going to ask the end as well. How do we refer to you? How do we ourselves go and see? I think a lot of us would love to benefit from this. So thanks, Carrie, for sharing that. I'm told screen time before bed is a myth. I was told I can watch TV during my wind down time, but only to watch a comedy or something not activating, nothing like drama. Maybe better to do an iPad with the light turned down. We talked a little about, but the TV itself is okay. Is that a controversial recommendation? So a lot of people are watching TV before they go to sleep. Is that something we should worry about?
What I would encourage you to do, first of all, it might depend on how much TV you're watching. If you're watching 2 or 3 hours, not so great. If you're watching an hour, okay. I would encourage you to experiment. I'd encourage you to stop all screens an hour before bedtime and do something different that is relaxing, calming, enjoyable, and do that for a week and see what happens with your sleep. And then you can make a more informed decision. I see all the time the people who stop their screens an hour before bedtime, because we do groups and individual, people who stop their screens an hour before bedtime invariably do experience some improvement in their sleep. So I would just encourage you to do an experiment. Everyone's a little different. Maybe for you, TV works and there's no real difference between not watching it versus watching it, but you won't know unless you experiment.
What are some natural catalysts of restless sleep, regardless of quantity?
Wait, some natural
Catalysts. Of
Like
restless,
what causes restless sleep?
I guess what are some things that help your sleep just be restful?
Oh, restful. Oh, I get it.
Yeah,
Yeah. Well, first, maximizing your sleep drive, so not spending too long in bed, getting sufficient activity during the day, relaxing before bedtime, and really managing stress throughout the day. Those are the two biggest things. Sleeping in the right circadian window, you'll get better sleep in a window that works with your chronotype. And finally, addressing any underlying sleep problems or other issues that can contribute to poor quality sleep at night. Those would be the four big things.
great. Yeah, that regularity really hit home. That makes a lot of sense.
Yeah.
I think a lot of us were listening to so many questions because we're like, oh, that makes a lot of sense for why my life is this way. And also patience. Dr. Dunn's saying, I guess I shouldn't have watched The Last of Us a few weeks ago before bed.
Probably not. And no reading, no looking at the news before bedtime, another favorite activity for some people. That's not going to help you relax.
I just want to, Dr. wind down. Dr. Nichols is talking, and a lot of people are saying what a fantastic grand rounds this is. Outside of comments like this, he has a very extensive comment saying how helpful this has been and a clear path today to helping us feel rested, our patients feel rested as well, our students and residents. But the number of questions we're seeing that, and I'm sorry to everybody, we're going to get through all of it, is the other great indicators of how powerful this talk was, how important it was. And I'll just say right now, you're always welcome to come and speak to us in the future. I'm sure would be very welcome. Thank you so much for all the work you do as well. And any call it how we can refer patients to you, or even I'm sure you have a lot of clinicians at Stanford seeing you as well.
Yeah.
way to-
Yeah. So you know, to refer to us, you go to to sleep medicine clinic and you select either insomnia clinic or circadian clinic. We do have some specialized clinics because there are different things we do depending on the presenting problem. That's all you need to do. So we definitely encourage referrals. We're always happy to help people understand, manage, get better sleep. And I'm so glad you found this helpful. It's always a pleasure for me to talk about sleep. It's a real pleasure to be invited to address you all in grand rounds. So I'm glad that the information provided seems to be useful.
Well, thank you again. And I hope everybody has a great and restful rest of the week. Thanks so much, Dr. Bard.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.